dear chairpersons, dear colleagues, C-reactive protein is an acute phase plasma protein produced by hepatocytes once triggered by interleukin 6. It exists in the plasma usually in very low quantities, in less than 3 milligrams per liter, but what's fantastic is that especially in destructive or bacteremic infections, it increases 7,000-fold. Nowadays, it's very easy to measure. It takes a minute or a couple of minutes to measure that, and that's why there's a very great clinical potential for the use of CRP. The other issue is that now people are also using that in cardiovascular diseases when the increases are only small ones, but I'm not touching that at all. I have been studying bacterial meningitis throughout my adult year, and everything actually started about 70 years ago when a couple of internists in that hospital where I was working as a young doctor in Helsinki, they had collected some cases of poliomyelitis and serous meningitis, which is viral meningitis. In all, they had 22 cases measured at various stages of disease 74 times and found out the method was very crude, it was semi-quantitative, but they found out that it was positive in 92%, but there were 8% in which it was not increased, and then they tried to explain why it was. So these were the viral diseases, and then a couple of years ago, they came out with another study in bacterial meningitis. They had 30 cases, and regardless of the etiology, it was always positive from the early beginning of disease. These publications were in a decades ago existing Annales Medicinae Experimentales Finlandiae. Actually, nobody read it, but anyway, it was an international journal. And then, as a young doctor, I thought that now perhaps I should look at the potential of CRP in pediatrics. And what I did was that I collected 16 cases of bacterial meningitis, you can see here, CRP, and these are the initial CRPs, first taken when they arrived to hospital. It was always increased, and versus viral meningitis here, about 25 cases, it was always negative except one. It was tiny, increased in 29 milligrams per liter, but it was something perhaps very, very small tissue destruction, because next day it was only 19 and the child was discharged healthy home. And then in the same publication, you can see here CRP measurement in hip meningitis. There was a fusion, and that caused another CRP increase here, but ESR sedimentation rate was sky high there. And when I compare that with the Coxsackie meningitis, ESR was very, very high throughout the disease, but CRP almost did not increase at all. And after that, I collected cases of viral and bacterial meningitis, and you can see that there's no question that CRP, and these are the first CRPs just after arrival to hospital, and you can see that regardless of etiology, they were highly increased. For example, these three pneumococcal cases, the history was less than 6 hours, so it was very, very, very short anamnesis. Now, several questions raised. How quickly does CRP increase? What is the cutoff level? How about immunocompromised patients? And what is the potential role in monitoring the cause of illness? Acute epiglottitis is something which many of you people have never seen. It's a hip disease and has two advantages. It's bacteremic, almost always, and then you can very clearly say when the child became ill. And that's something quite special. And when I interviewed these 40 children's parents, I found out that if the history was 5 hours or less, then it was negative, and then it increased, so that within about 6 to 11 hours, it clearly increased. And as far as the cutoff level is, that I have using this 20 milligram per liter as the first increased level, but as you can see here, that if you increase the cutoff level to, let's say, to 100, then that's fine. Sensitivity will be less, but specificity much better. And immunocompromised patients behave exactly in the same manner, no problem. And then when you follow up meningitis, here you see really cases. If everything went well, then CRP normalized within a week and remained low, but in relapsed cases, we had 3 relapses, it re-increased, and unfortunately, we had 9 children who died, and there was a very high CRP, which never really came down. Now, we have been using CRP in a number of other diseases. The meningitis, here are just 50 cases of osteomyelitis. You can see here that CRP comes again down very nicely within a week or so if the child improves. ESR, or sedimentation rate, is it actually raises quickly, but it comes down very, very slowly within 3 days, 30 days or so. So, without a little exaggeration, I would say that actually CRP is likely the most informative laboratory index when you are treating severe, especially bacteremic infections, in which obviously the tissue destruction is quite intensive. So, I highly recommend that in clinical practice. It's cheap, quick, and very, very good. Thank you.